Dr. Arjun Dayalan, he is a fellowship-trained orthopedic surgeon specializing in hand and upper extremity surgery. He is a board certified by American Board of Orthopedic Surgery and is a member of the American Society of Surgery of the Hand. He completed his fellowship in the hand at Leahy Clinic in 2023 and his residency at orthopedic surgery at UMass Chan Medical School in 2022. Dr. Dialen was a hand surgeon at Ortho Virginia and Virginia Beach and currently now practices at New Hampshire Orthopedic Center. I want to thank him for coming and speaking to us today on his procedure, and I'm introducing Dr. Dialen.
Thank you, Karen, for that kind introduction. Can everyone hear me okay?
Yes.
Perfect. I'm just going to go ahead and share my screen so that you can all see my PowerPoint here. And I apologize in advance if it sounds like I'm back in middle school going through puberty again. I have a 2.5-year-old and a 1-year-old at home, and they're sick. So I'm sort of getting everything that they have. You know how that goes. So if I pause to take a sip of water or you notice the halls in my mouth, that's why. I'm excited to talk to you guys today about office-based WALANT type surgery. And in particular, I want to show how this improves access, recovery, and value for injured workers in particular. I wanted to take a moment to briefly just introduce what WALANT is. So WALANT is an acronym. It stands for Wide Awake Local Anesthesia, No Tourniquet. This is a major push within the world of orthopedic surgery and hand surgery in particular, because it's allowed us to do a lot of things that we previously would do in an operating room setting, whether that's in the hospital or an ambulatory surgery center, but do this within the office. I don't really want to focus on the details of WALANT today from a medical standpoint because it is a technique, it is a tool. What I really want to focus on is to show how this particular tool and technique can be used to create a faster, more predictable pathway for injured workers who may need hand surgery. There are 6 pillars that I want to hit on today, and we'll go through each of these sequentially. The first is to show how this can improve the speed of treatment and ultimately allow for earlier return to work. There is a global lower total cost of care when you use this particular technique. There's better communication, both with folks that are working on the workers' compensation side, as well as between the doctor and the patient. And that's really been a breath of fresh air for my practice in particular. Next is predictability, because the patient is awake for this type of procedure. And you'll see there's many different operations that can be performed in this manner. You're able to kind of coach them through the expected outcomes, as well as what is safe to do, what's not safe to do. And as you'll see, ultimately, this also improves access because we are kind of circumventing the traditional framework where patients need authorization and preoperative testing and ultimately need to find block time within a surgery center or a hospital. This allows everything to be done in the office. And I'll show several case examples towards the end that actually demonstrate how this could be used in real life. Some of them are my own cases. Some of them are cases that I've borrowed from some other hand partners of mine that are within the NOA umbrella. And some of them are just examples of cases that can be done that I've sort of used from other mentors that I've had throughout my training. So as I mentioned, WALANT is an acronym that stands for Wide Awake Local Anesthesia No Tourniquet. And it was really popularized by this gentleman here, Dr. Don Lalonde. He is a practicing plastic surgeon in Canada. This technique has existed for several decades, but he's the one that really kind of brought it to the forefront, particularly for hand surgery. And the way it works is that you use a mixture of 1% lidocaine with epinephrine, and through a series of injections, you can provide a large area of a field block that gives the patient some pain control. And the epinephrine actually causes some vasoconstriction, which provides a relatively bloodless field. The major advantages are that you don't need any kind of IV sedation, there is no general anesthesia, and there is no tourniquet related pain. He's actually published a book on this, which is now in its 2nd edition, and it's really spread like wildfire all throughout hand surgery. And as I mentioned, hand surgery is sort of the forefront for this, but really this can be applied to any type of operation anywhere within orthopedics and even outside of that within general surgery and other areas. So I wanted to introduce this technique, but really show how it can be applied in the day to day. Once you have that field block, the patient's hand is then numb. And really, at that point, they're entirely comfortable, they're conversant. You can actually test motion and function. So I've used these in a lot of scenarios for tendon repairs. That previously is a fairly challenging area within hand surgery in particular, flexor tendons, extensor tendons. Part of that is getting the tension right. Part of that is making sure that the repair is robust enough that once the patient begins their therapy, that it holds. These are all things that we can know in real time and the patient can actually see, and it really increases the buy-in that they have, both towards their therapy but also towards their overall recovery and what their functionality can be. This has been studied extensively in the literature. As you might imagine, the epinephrine portion of this has been a stumbling block for several decades for folks. There is that age-old saying that there are certain areas within the body that epinephrine really shouldn't be injected. The fingers was one of them. And the thought was that it would clamp down on blood vessels and really cause a major problem for ischemia. Now, we've shown over the last several years with thousands and thousands of cases that not only is that a myth, but this is actually incredibly safe and preferred in many different ways. The major changes that this tool allows is that we can circumvent the OARD-centered pathway and really move towards an office-centered pathway. And it avoids a lot of the preoperative clearances. There's really no fasting that's necessary. There's really not an IV in any of these situations. It completely removes anesthetic recovery from the equation. And there really is no post-operative care area because the patient really just comes in their regular street clothes to the office, has their hand numbed up, and after a period of time for that numbing medicine to set up, including the epinephrine, they then have their procedure and they're able to walk directly out to the lobby area and exit that way. So it becomes much, much easier to schedule. It's far easier to coordinate. It's much less hassle for the patients. They have repeatedly said how much they prefer this and the simplicity of this approach. But certainly there's also a lot of other reasons that I think that it warrants some attention. So we'll get on to those 6 pillars that I talked about. The first of these pillars is that it improves the speed of treatment. Now, we all know delays can happen, and delays are not only detrimental to the patient because it impairs their ability to get the appropriate treatment, but it also can be expensive. That's time out of work. When we're waiting on hospitals and surgery centers to open up block time, especially when there are urgent cases that need to be addressed. This offers us an alternative to do things in the office setting where, you see that example of a typical surgery schedule board. They might be completely booked. They might not have an opportunity for these cases to go on the board. Whereas the office is wide open and it really just comes down to the staffing availability and whether you would have the equipment, which is just something that gets purchased up front. I have a little bit of experience actually setting this up. I did it for the first time in Virginia when I was practicing with Ortho Virginia. And you would think that it takes a lot of tools and equipment and setup, and it really isn't all that much. It was done in my regular clinic room. There's no special lighting that was necessary. It required a purchase of a very small surgical tray, which I'll include a few pictures of so that you can see in the later slides. And that really was the upfront cost. And once you have that system set up in place, your typical MA that you would use in your office now doubles as your surgical scheduler as well as your assistant during these cases if that's necessary. And so that's why I put that second schedule on there, because it really opens up a lot of opportunities for patient to get earlier and definitive care, which ultimately I think really decreases the number of visits in the long term and gets folks back to doing the things they want to do. Here's a typical pathway for what surgery might look like today. You typically get the referral, you get an evaluation in. There may be some preoperative clearances and testing that need to be done. The patients have to fast. There's an anesthetic screen that happens. You're typically held up by scheduling constraints from the surgery center or the hospital. And there's a fair bit of time that they spend in the recovery area, making sure the anesthetic washes out of their system. The first few days tend to be a bit difficult with some of the side effects that come along with that. And as I've emphasized before, we really skip through a lot of those steps. And when I think about quality, we really get it down to the key things here, which are developing that doctor patient relationship, getting patients in quickly, and getting them back to doing the things that they want to do in a safe way. The second pillar is all about that earlier return to work. Now, our goal here is safe function. What we want to minimize is any unnecessary time out of work. So we're not really speeding anything up with surgery. The goal is not to go faster during the case or really to get patients back to work sooner than they feel comfortable or sooner than would be safe. The idea is to minimize all of those in between delays. In other words, the delay that might get them in to see me in the office, the delay that might get them in for a procedure, the delay that they'll have in the recovery from anesthesia, and the downtime that comes with some of that sedation. Really, with a lot of these soft tissue procedures, we can get folks back fairly quickly, and the restrictions are very obvious. And I'll talk a little bit more about that in the communication section. This tool has changed not just the actual procedures that we do, but even the way in which we do them. I'll give you an example with trigger fingers in particular towards the end of the slide about how these modern techniques can really keep things fairly minimally invasive for patients and still get them excellent outcomes. At New Hampshire Orthopedics, we have pretty clear expectations about what return to work looks like. And it really is based on the individual and their work-related responsibilities. We're always pretty clear about a duration for the restriction as well as when we would want to see them back. And we're always looking for modified duty opportunities so that we can get folks using their hands. We know that the use of the hand, it helps recovery mentally, but also physically. And I think that, having that clear line of communication with the patients, especially because they're awake and participating with you throughout this whole process, really speeds up that side of the work comp care. This is something I feel fairly passionate about. This is a global improvement, I think, using this technique, not just in the workers' compensation realm, but really about healthcare in general, which is if we can cut costs and we can reduce facility utilization, reduce the need for anesthetic costs for particular cases, reduce all of the logistical hurdles that may happen that preclude patients getting into the operating room, we can really decrease the lost time from work. We can improve claim progression. And ultimately, we're presenting a cost savings for the patient, but also the health system at large. And we've looked at this from multiple different angles, both the actual facility fees, the lost time from work, as well as even simple things like draping and the equipment that's required in a hospital or a facility setting. There is so much waste that goes on in all of those, where the pictures that I'll show you in a few slides, there's pretty minimal equipment that's necessary using this type of technique. And I think that really lends to a bit of a green initiative that is a happy byproduct of using this particular technique. There's a pilot model that we've come up with that we are fairly interested in as a New Hampshire Orthopedic Alliance. And this has been proven in several different states. This is some of the cost savings that you can see for some of the more routine hand and wrist procedures. Immediate cost savings of 33% for something routine like a carpal tunnel release. When you compare it, doing it in the office versus doing the same case, even under local anesthesia with sedation at the surgery center. Same thing with the trigger finger release, assist excision, even fracture repair can show significant savings just by moving things out of the surgery center into the office. The fourth pillar is really about better communication. This is something that I think is invaluable. And I really believe in this when I say it. Communication is a clinical intervention in workers' compensation cases. We know that sometimes the injured worker can feel lost in the overall health related outcomes, the time that they're off work. They may sometimes feel like they're in a little bit of a limbo. The nice thing about this technique is that it removes some of the uncertainty with regards to surgery. Um, I'm able to talk with them directly, preoperatively, during the case, as well as postoperatively. So they have an immediate assessment of what the expected recovery will be and also what their function will be. And that's why I think the communication part there is really a real clinical intervention, because if I was doing a trigger finger release and the patient was asleep, they would wake up and they would take my word for it that everything went well with surgery. But when they're awake and they're actually seeing me release the pressure on that tendon, and they're looking at the tendon as they move their finger, and they're seeing that they have full range of motion, that their finger that they walked in just earlier that morning that was clicking and catching no longer is catching anymore. And they can see that with their own eyes, and they can see that it took, a few minutes to do that procedure. They're immediately bought into the therapy. They understand what it takes to do the procedure, and they're immediately bought into what it takes to recover from that procedure. And it really kind of simplifies both the surgical plan as well as the expectations for the postoperative recovery. I think this matters a lot in tendon repair, as I mentioned before. If I can see that the tendon repair is holding and the patient can see that, we know that stiffness is a major complication from flexor and extensor tendon repairs. I can give the therapist a clear answer about how much I want them to safely push this patient to get them the maximal function that they can get sooner rather than later, rather than being very restrictive with them for 4 to 6 weeks and then hoping that there is no complication that develops afterwards. All of these expectations are really known upfront, not after a complication happens. At New Hampshire Orthopedics, my typical scenario here is that, they get a diagnosis. We talk to them about operative and non-operative treatment options. They get an expected recovery date. They have a clear understanding of their work restrictions, and all of that gets updated in real time on the day of the procedure, as well as during their postoperative follow-up. And it really allows the time for me to clarify for them what their restrictions might be that could affect their job placement. And as I mentioned, because it's local anesthesia, it really has allowed us to do a bit more of the minimally invasive approach, which ultimately I think gets people back to work faster. The fifth pillar is really predictability. I think the thing that really makes for happy patients and happy doctors and happy workers is that they really understand what it takes to get them from an injured state to a functional state. And some of this is logistical. It comes down to predictable scheduling and fewer anesthesia related cancellations. Some of it is regarding restrictions for work related activities after common procedures. And some of it is really the patient experience. And I think that can't be understated. Patients can drive themselves to and from the office. There's no need for fasting. They're there seeing everything. It can be disconcerting for a patient to have an IV put in, say goodbye to their family members, and then, go to sleep with anesthesia and wake up and feel disoriented and not really know exactly what happened. At least in this WALANT technique, they're really awake and understanding for everything. And I really think it gives them the satisfaction that everything that they came in for has been completely clear and that they were involved in that process all the way through. This is just a hint of a case that I'll show you later on. This one really talks to the idea of improved access. And I think this is the real competitive advantage here. Not only can we do things quickly, but sometimes there are urgent things that really can't wait on hospital resources. So this becomes a competitive advantage to do things in a timely manner in the office. And I'm not talking about, weeks to days. I'm talking about days to hours as far as getting, urgent injuries treated. And I'll show you an example of that with this particular gentleman here. The other thing I wanted to comment on is that the sicker the patient is, the more they are a candidate for WALANT type surgery. It's been a major paradigm shift for me as well as our hand surgery community at large, that if a patient is, say, 90 years old and they have a carpal tunnel or a trigger finger and they've been dealing with this for a long time and they're very functional, but this is the one thing that limits them, we may previously had said, look, maybe the anesthetic risk is not worth it in this scenario. Maybe they have a lot of cardiac or medical comorbidities that would preclude them from really having safe surgery. But if they were to do an under local, now they're the ideal candidate. They don't have to stop any of their medications. They don't change their routine in any way. If you're on a blood thinner, you don't stop your blood thinner. The epinephrine really clamps down on the blood vessels to the point where this becomes relatively bloodless, and you can do safe surgery even in folks that otherwise may not have been surgical candidates, including those who have very complex medical conditions, because this is fairly analogous to going to the dentist and having everything numbed up and having a procedure done and then walking out of there fully intact. There's an art to indicating patients for this. Not every patient is the ideal candidate. And so I'll talk about when it's a good fit. And then the next slide, we'll talk about who might not be a good fit. The patient who is the best fit here is someone who is motivated, who is comfortable being awake, who has a common soft tissue procedure, and sometimes even more complicated fractures or tendon repairs. Those medically complex patients who would actually benefit from avoiding all of the anesthetic risks, and for those who really need more efficient scheduling and rapid functional planning. And this is an example of what that might look like. This is a typical hospital, or excuse me, office clinic room. There's a stretcher there. There's very minimal draping that happens. There's a few blue towels that are draping out the field that has been prepped. There is a headlight that really provides all of the light that you would need, and a very small table that really has just basic surgical equipment to do this kind of thing. And as you can see, patients are fairly comfortable doing it in that manner. And I'll show you a few pictures later on where sometimes patients are a little bit curious and they want to kind of peek over the drapes and see what's going on. And I'm happy to sort of involve them in that as well. But it is not for everyone. And even though I say these are the few contraindications to WALANT, these are the things that you really have to screen out for, because we don't want to expose anyone who might not be appropriate for this type of setting. Some of those patients are those that have severe vascular compromise or poor perfusion to begin with. Again, that is more the epinephrine risk. When it clamps down on your blood vessels, if you have existing poor perfusion, you can actually cause an ischemic digit. So that is something that we have to be very sensitive to. There's not a lot of patients that really fall in that very severe category, but that is something that you have to screen for. Although it's very rare, there are some folks that have a true allergy to local anesthetic, whether that's lidocaine or any of the other medications that are injected. So you always have to ask them if they have any situations where they had a truly dangerous allergic reaction. There are some patients that truly just aren't comfortable being awake, and I can counsel most patients through relatively minor 5 or 10 minute operations, but some of them have severe anxiety, and they might not be the best patient to do this type of procedure on. Some procedures are just too incredibly complex to be done in an office setting. Now, that I should have a little asterisk, because in Brazil and other areas around the world, in Europe in particular, there's almost no limit to what can be done with local only anesthesia. Wrist fractures, elbow fractures, all of these things have been published and done safely. We're not there yet in the United States. I think we will get there as a hand surgical community in the future, but time will tell where we go with that. In general, while there are many improvements with WALANT, there is nothing that supersedes clinical judgment and a direct communication with the patient about whether this is something they would feel comfortable with. That is first and foremost. Safety is first and foremost. Everything else, the convenience factors, the logistics, that's the cherry on top. But medical care, we never compromise that, even if it would be more convenient to do it in the office. This is just a very small list of what can be done, but you'll see many of the common hand surgery and wrist surgery conditions here: carpal tunnel releases, including endoscopic carpal tunnel release, which is my personal preference, and we can get into that at the end if you'd like. Trigger finger releases, Dequervain's tendonitis, foreign body removals, mass excisions, ganglion procedures, certain tendon repairs and tendon transfers, certain fracture fixation, and even percutaneous procedures. My particular current interest is in ultrasound guided, minimally invasive procedures. I'm happy to talk about that a little bit at the end. I think ultrasound has become an incredible tool that shares a lot of similarities to the WALANT technique. It's another tool in our toolkit. You can do things. It's almost like my musculoskeletal stethoscope. It allows me to see inflammation, see synovitis, see foreign bodies that otherwise I wouldn't be able to see if they don't show up on X-ray. Map out where my tendon repairs are going to be, find the proximal tendon stump so I'm not making large incisions to get there. It really has caused a lot of advancements for me, not just procedurally, but even diagnostically for patients that might otherwise continue with conservative care. I can now have some confidence in saying that the ultrasound has shown me exactly what I would need to do, and in a lot of ways has saved on ordering MRIs and other tests that may have been necessary previously, but can be diagnosed in a lower cost and non-invasive manner. The safety and patient experience part of this is paramount. I did spend a little bit of time earlier showing you the slides with the literature that supports that. That's fairly well established now. The additional things I wanted to highlight are that there's no tourniquet, so there's really no pain associated with that, and no sedation or any of the anesthetic side effects. Our patients at New Hampshire Ortho have been very happy with this technique, and really there's quite minimal pain. I tell them that the injection stings and burns and nothing really takes that away. But if they can get past that part, everything else is smooth sailing. I showed this picture here because there's a lot of room for using technology, even for the patients that otherwise might be very anxious, to decrease the burden of doing cases like this in the office. You can see this patient here has virtual reality goggles, but it doesn't need to be that fancy. You can distract them with conversation. You can distract them with headphones. There are folks that have a screen or something playing up on the screen on the ceiling so that they can look at it. And some patients really want to be involved, and you can really sort of show them exactly what you're doing and get them engaged in it as well. So there's a lot of advancements that we've noticed with the patient experience side of things that I think you just wouldn't be able to do in another setting with a different technique. These are several, Google reviews that talk about exactly how pleasurable this experience is, and most patients are very pleasantly surprised that this is something that could be done, and not only that, but it was actually better than the alternative. So I'll get into a few case examples here, just really brief, to review some common conditions, carpal tunnel being a major one. We often see this: numbness, nighttime symptoms, loss of grip and power. Um, After the patient has exhausted all the non-surgical treatment options, if they are indicated for surgery, this is something that can very easily be done in the office. This is a picture actually from the Mayo Clinic. You can see here this gentleman is sitting up. He's in his regular street clothes. He's kind of looking over and seeing what the docs are doing there. There is a clearly sterile technique being followed. However, he's participating. He's kind of looking. There are some medical conditions that he had with COPD and others that really he couldn't even sit flat. And so this position of him essentially being seated was the best thing for him. And he's really able to kind of take a look and see how a high volume, high value procedure like this can be done in an office-based setting. And in this case, it provides access. It improves communication as you sort of talk to them and show them the ligament as you're dividing it, and the nerve, and what it looks like afterwards. And for me, it gives me an opportunity to give them some clear restrictions on exactly why I am limiting their grip and their power, why they're going to have some hand and palmar sensitivity after this, and when I would expect that to resolve, and what might be safe to do so that they can get back to work quickly. A trigger finger release is again very similar. This is probably number two in commonality: manual workers, repetitive grip occupations. These are the sorts of things that can cause those catching fingers that tend to cause major pain in the hand. Here's an example of what a typical open surgical trigger finger release would look like. In my evolution, those incisions have gotten smaller. I've gotten to using absorbable sutures and skin glue. Patients really don't have any major restrictions from me, and doing it in the office has really minimized any sort of operative delays. But there's room to grow with this. The next frontier for me has been percutaneous trigger finger release. I mentioned ultrasound before. Using the ultrasound, I'm able to see the area within the A1 pulley or the A0 pulley. Sometimes it's the A2 pulley, exactly which spot in real time, dynamically, as the patient moves, that finger is getting stuck. And once I identify that spot, using the WALANT technique, I'm able to numb up that area. And I just use the tip of an 18 gauge needle to divide the offending fibers. And the patient is able to participate with me. And it's really dramatic for them when they see, I came in, my finger was stuck, and then we work together. And it truly is a collaborative process because I only release as much as I need to until they're not locking anymore. And it's audible. You can hear those bands being released, and patients really get a kick out of that I can see with the ultrasound, and also that you can hear that release being done, and they just get a band-aid after that procedure. The scar is really imperceptible, and that really shortens the time that they're stuck in conservative care, trying a cortisone injection, seeing if that works, waiting a few months, maybe another injection. The success rates are so high with a percutaneous release, and because there's no wound, I'm able to inject cortisone at the same time, which really speeds up their pain and inflammation as far as recovery. Folks have been so happy that their return to work planning begins the second they walk in the office, because I know that I have a reliable treatment solution for them that really doesn't require much downtime at all. So there are some advances using Wallant as a tool, but also incorporating some of the other things that we've chatted about. And that case that I showed you before, it doesn't have to be the bread and butter. You could have open fractures that are urgent and that really need complex but efficient care. And we can get those patient access to reduce the time from the ER to the OR. And I'll show you this particular patient, how that exactly went. This was a case from one of my partners. 67-year-old male had a wood splitting injury, very significant deformity, both tendon as well as soft tissue damage, as well as bone damage, as you can see here. The patient was sent immediately from the emergency department to the on-call physician. Let me just make sure my slides are advancing here. And was able to get the fracture pinned, was able to have the soft tissue injury repaired with suture repair for the tendon injury, um, all within 4 hours from the time of injury. It just impossible in a situation other than we can do this with local anesthesia in the office. And I've done similar things in my clinical practice where infections, foreign bodies that have gotten lodged in injured workers, dorsal hand or palmar hand, you can identify them with ultrasound, take them immediately from the urgent care or the emergency department, localize it, and remove that within hours from the time of the initial injury. It is very satisfying to give that level of care to patients. They're very appreciative of that. And even complex injuries like this ligament injury. This is actually an orthopedic surgeon who had a UCL injury on his thumb, sometimes called the skier's thumb, which really involves a fairly long process of time off of work, limitations with pinch and grip. But if you're able to get to them early, the tissue is actually of very good quality. And oftentimes you don't even need complex anchors or internal braces to repair that. It sometimes can be as simple as a suture repair over a bony bridge. And that's exactly what was done in this case. The ability to do this under local anesthesia also allowed active range of motion testing, so you know how solid that repair is. So this orthopedic surgeon actually went to work immediately. He was able to scrub in and do a case. That's a picture of him giving that thumbs up there with his repaired thumb, knowing that there is some stability that was actively tested in real time. So it's not just about, cost savings and confidence in the repair. It's really about higher quality care. It allows us to coordinate and get people back to doing things that otherwise would not be possible. I've included here, just in the sense for time, a few frequently asked questions. I'll just sort of hit the highlights here briefly, but I do want to leave some time at the end for questions that everyone may have. These are some of the common things that my patients ask me. Can you drive home? And the short answer is yes. It's local anesthesia. Your hand will be numb, but it will be motor intact, so it will be functional for you. So patients really do drive themselves back and forth after even more major procedures like this done in the office. The procedure itself, is it painful? And I tell them typically, if you can get over the injection, the procedure itself is not painful at all because their hand is numb. We talked about who might not be a good candidate, what to do for patients that are anxious. Um, for folks that have other medical conditions, diabetics in particular, I find them to be one of the best candidates for this procedure because if they're taking insulin, or my patients that are on blood thinners, again, excellent indication for this because you don't have to stop any of your medications and worry about when I can resume or restart. All of those can be done with no interruption, just with the effect of the lidocaine and the epinephrine. There's always the question of safety, and particularly patients ask about infection risk. As you saw, the draping is pretty minimal. Patients are sometimes peering over, looking at the wound. It was thought previously that perhaps there was a higher infection rate. Actually, the infection rates are identical and in a lot of cases lower. And we don't really have an explanation for why it could be lower. Maybe patients are really bought into exactly everything that was done. And because you're able to counsel them as a surgeon, they're able to protect the wound a little bit better. Those are my guesses, but it definitely is not higher. We talked about the speed of access. We talked about work restrictions. Um, and the bottom line is not every case can or should be done in the office, but it really expands the ability that we have to provide high quality care for our patients. And certainly, if you have any of these things that you really would want to refer patients early, acute traumatic injuries, open fractures, crush injuries, retained foreign bodies, progressively worsening symptoms, things that really are becoming painful and affecting your job function, this is the perfect scenario where WALANT really gives us the opportunity to intervene early. And for folks that are local to New Hampshire or not, we have a fairly robust system where we do this. This is something that I've implemented since the time that I started, and it's been met with really a lot of satisfaction on the side of patients. We have a pathway in place to sort of get them in, flag urgent injuries, and make sure that we're providing the highest quality care that we can. The bottom line that I wanted to leave everyone with is that WALANT as a technique improves the overall workers' compensation pathway because it allows us to provide faster access, earlier return to work, lower episodic cost of care, better communication with patients, a more predictable recovery, and overall improved access to the definitive care that patients are looking for. As you can probably tell, this is something I'm really excited about. I've done it now as a pilot in 2 different locations. Obviously, this is taking off like wildfire within hand surgery, but I think it is really exciting to move things out of the hospital setting and really put patients back in control of their care and give them an opportunity to maintain their decency, some transparency within the healthcare system, and really get their involvement so that they feel like they're really being heard and that our goal is clear to them, which is that we want to give them the best quality care and get them back to the maximum level of function that we possibly can. So with that, I'll stop sharing my screen and stop talking. My voice kept up with me throughout, so give everyone an opportunity to maybe ask some questions.
I'm actually seeing a lot of very positive in the comments. I think the one thing I would ask is there's a lot of case managers and professionals in a lot of the states. Is there a way that they could find a physician that's doing this in their area?
That's a great question, Karen. Thank you. Um, a lot of hand surgeons will advertise this now on their personal websites. WALANT is sort of the acronym to look for. Whether they do that in the office setting is unpredictable. A lot of folks are doing this technique, but just doing it within the hospital or in the surgery center, which obviously there are some advantages to that, but nothing really beats doing it in the office as we're doing, Karen, as you know, in New Hampshire, because it really eliminates a lot of the logistical hurdles. But there is no database or anything where you can look up folks and whether they're doing this. And unfortunately, I think would require a call to see if that's something the particular hand surgeon is interested in doing. If I'm not mistaken, Karen, I think we're one of the few practices within New Hampshire that's doing this in the office. So while I do think this is the future of where we'll go, it's certainly not incredibly commonplace yet, but I think we'll get there.
What made you interested in looking at this as an option?
Good question. I actually wasn't trained to do this per se. I had excellent mentors both in residency and fellowship, but this was a developing science, and so it was not something that was in their armamentarium. This is something that the more the literature came out on how beneficial this was, I decided personally that this was something that we had to offer patients. This is something that we needed to provide. And so we were able to do that both with collaboration from my previous practice and then certainly within New Hampshire Orthopedics with the support that you've provided, Karen, as well as the rest of our administrative staff here. I just think this is one of those things that, you know, we're doing the same procedures that we would do surgically otherwise. We just need to do it in a different way. We need to do things a little bit differently so that we can keep patients involved and provide them care. And as you might imagine, I didn't touch on this part, but there is an efficiency component to this when you're able to do this in the office. And so when we talk about serving the underserved or patients that otherwise might be waiting um, for several months to get the care that they need. If you're able to do it in the office, you have a lot more rooms available for you to, you know, be able to flip back and forth and be able to offer that level of care rather than wait for a surgery center where you might only have a set number of rooms or staff available to you.
One thing that you talked about is it's a little off topic, but the use of ultrasound and what kind of equipment do you use? Do you use something different in the office?
So we have a handheld ultrasound. The model is Clarius, although that's not necessarily relevant. Handheld ultrasounds in general are very small, so the one that I use is probably about that big. It has very high frequency, so that for hand and wrist particular procedures, you can see the anatomy in a very detailed way. It connects via Bluetooth to an iPad, so that can be sent immediately to a PACS system so that it can be saved and recorded. I'm always showing patients that they seem to get a kick out of actually seeing the tendons move or, you know, seeing a cyst or something like that. So the diagnostic pathway is shortened significantly because of that as a tool. But certainly there's a therapeutic side as well because it helps guide injections, it helps guide aspirations, it helps for trigger finger releases, as I mentioned previously. So it's just another tool that can be used in many different ways. I did see a comment about ultrasound guided carpal tunnel release. The more that we find options for this, we realize that we can keep things less and less invasive and sort of get things done in a different way. So I think just using the tools that you have available is the way to go.
And you did mention something about using ultrasound as diagnostic.
Mhm.
That's sort of a different philosophy. Is that something you feel will expand?
Absolutely. So I made the joke during the talk that the ultrasound is like my orthopedic stethoscope, but I really believe that. This allows us to see things in a different level. It hones my physical exam in a way because I can actually confirm what's happening in real time, whether there's inflammation within a joint along tendons, whether there's a mass or not. You can diagnose ligament injuries with that. You can diagnose fractures with that if for some reason you're in a situation where you can't get an X-ray. Um, it's non-invasive. So for kids that might have issues, it's clearly a better diagnostic modality there. If you have a pregnant patient, I avoid x-rays on those patients, and I use ultrasound instead. So there is a big diagnostic component to where we go with ultrasound in the future. And I think the better the technology gets, the more uses I find for it within the upper extremity.
I want to thank you very much. I see all very positive comments in regards to what you brought forth today. If there aren't any more